This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. This is a case which has a post-operative corneal edema on the first post-op day. This is operated by a resident doctor and it is presumed that over a period of time it's going to clear. But on the fourth post-op day, the edema still persisted. So an anti-segment OCT was done and it showed an area of detachment in the inferior half of the cornea corresponding to the area of corneal edema. And the detachment was quite large and it deserved attention. The first lesson is, in a non-resolving edema, always get an OCT done. That really helps us to rule out the Descemet membrane detachment. Now the operating surgeon did not have an idea when it happened, so we went back and tried to look at the videos and it wasn't very conclusive at what stage it happened. The only guess was that during nucleus maneuvering it would have happened, or a second option would be during the side port hydration. So these are the two steps where it was suspected that the Descemet membrane detachment would have happened. Nevertheless, now we need to manage this. Let me pause the video and spare a moment to discuss about Descemet membrane detachments. The inferior Descemet membrane detachments are very difficult to treat, unlike the superior Descemet membrane detachments, because whenever we use the gas or an air to support the Descemet membrane detachment, the superior ones get adequate tamponade because the bubble always moves up, and the superior detachments, it's easier for them to tamponade. However, the inferior detachments are difficult because the bubble tends to move up and the inferior part of the area doesn't get the necessary tamponade effect. So preferably whenever we have an inferior detachments, the choice of gas always is either SF6 or C3F8, simply because they stay inside the eye for long, and if we can ensure that the patient lies in a supine position for a prolonged duration of time, the chances of reattachment quickly are quite high compared to just using an air. If it escapes out, again the chances of redetachments are very high. So inferior detachments are quite tricky and we need to use the right maneuver. So in this case, I am planning to have an overfill of the chamber, and to prevent pupillary block, I plan to do an inferior iridectomy. So the surgery is now being done under peribulbar block. Speculum is placed. I am making a separate fresh side port entry. For mixing the gas to the desired concentration, we're taking 0.7 ml of C3F8 gas and then we're mixing with air to get the total content in the syringe to 5 ml. So 0.7 ml of gas in the total volume of 5 ml of gas gives rise to a concentration of 14% of C3F8 gas, and that's the concentration which is thought to be isoexpansile, and I'm going to use that concentration here. The cannula is placed well within the antechamber before inflating it. Once I'm certain that the cannula is inside, the gas is injected into the antechamber. And to do an inferior iridectomy, I'm making a stab incision in the at 6 o'clock position. This incision has to be very short. We want to have a very small corneal length here so that we can access the iris very easily. The iris is got hold, a small iridectomy is done, and the incision is closed with suture, and that's it. I'm patching the eye and asking the patient to lie down as much as possible, and the chamber is again refilled with the same gas once again. I just want to maintain the pressure for a little bit more time. After maybe 5 minutes, I let out the air a little bit. And these are the first day post-op pictures, and the inferior cornea is cleared off. We can see the gas bubble size has shrunk. It's about 3/4 fill of the chamber now. Nevertheless, we are going to ask the patient to maintain a supine position for as long as she can have, so that we don't have any redetachments. And these are the OCT pictures. And for a couple of weeks, the gas bubble is decreasing in size, the Descemet membrane remains attached, and the cornea is clear. To summarize, so video reviews are a great way to analyze where things went wrong. Intraoperatively, the surgeon hadn't diagnosed a DMD. He was totally ignorant of presence of any DMD during the surgery, but when we go back and review the case, at this step, when the surgeon is trying to introduce the cannula inside, this is the irrigating cannula, we can see a wave which looks like something, the OVD getting displaced, but in fact this could be the step in which the Descemet membrane lamellar separation could have happened here. it doesn't have a free edge. So there is a lamellar separation of the DMD, and this has been missed intraoperatively by the surgeon. After putting the intraocular lens, when the surgeon is trying to irrigate out all the OVD, even now we can distinctly see a line which is starting from the left side port and extending all the way up to the right side port. And the appearance of the cornea beyond this demarcation line is slightly different. As he's trying to remove the OVD, we can see intracorneal waves going on. And this is a surefire sign that possible DMD is occurring. And this DMD is quite huge. It's starting from these two side ports and extending all the way up to the inferior limbus. And it is a lamellar detachment. That's what the OCT is revealing. And so we have a task at our hand. So let's see how it has to be managed. I prefer to use gas tamponade for inferior detachment simply because the gas stays longer and provides adequate tamponade for the inferior quadrant, which is quite tough to manage. When you're trying to do an overfill, especially with a SF6 or C3F8 gas, it is handy to have a peripheral artery in place to prevent pupillary block, which is a realistic possibility. That was it. Thank you for watching and hope you found this helpful.